Order, order. The sitting is resumed. I now call Mr. Adrian Saunders. Mr. Saunders.
Thank you very much, Mr. McRae, and a pleasure to speak under your chairmanship, I think, for the first time. Diabetes is the fastest growing health threat in the UK, in the EU, and across the globe. If I just talk a little bit about what diabetes is, it's a condition where there is too much glucose in the blood because the body cannot use it properly. This happens because the pancreas does not produce any insulin, or not enough, or the insulin it does produce is unable to work properly. This is a problem because insulin is the key that unlocks the door to the body's cells so glucose can enter them. So with diabetes, the body is unable to use glucose as fuel, and instead glucose builds up in the blood. Now, there are two main types of diabetes, type 1 and type 2. They are different conditions with different causes. The treatments can be different too. Both types are serious, lifelong conditions that can lead to devastating complications if they're not managed well. But with the right treatment and support, people with diabetes can reduce their risks of developing complications. People with type 1 diabetes cannot produce insulin. About 10% of people with diabetes have type 1. I myself have had type 1 diabetes for nearly a quarter of a century, and I'm still here. No one knows exactly what causes it, but it's not to do with being overweight, and it is currently preventable. It isn't currently preventable. It usually affects children and young adults, starting suddenly and getting worse quickly. People with type 2 diabetes don't produce enough insulin, or the insulin they produce doesn't work properly. 85 to 90% of people with diabetes have type 2. They might get type 2 diabetes because their family history, age and ethnic background puts them at increased risk. They are also more likely to get type 2 if they are overweight. It starts gradually, usually later in life, and it can be years before they realise they have it. There are, of course, exceptions to both. There are people quite old in life who can become type 1. There are people quite young, children, who can have type 2. And it isn't always a consequence of the weight that a person is carrying at the time of diagnosis. As with all things, the exceptions make for a difficult and comprehensive diagnosis of precisely why these things are happening and how they can be prevented. Around 3.2 million people have diabetes, and diabetes costs the NHS over 10 billion a year. Within the EU, 1 in 12 adults has diabetes, and 1 in 3 people with diabetes apparently do not know they have it. In this country, we've done a lot of work on trying to find what was referred to as the missing million of people who had diabetes but had not been diagnosed. Now believe that that figure is around 750,000. So around 250,000 people have been diagnosed as a result of greater awareness. And I'll be referring to some of that a little later on. Now, according to the International Diabetes Federation, globally, there are 382 million people with diabetes, and this is expected to rise to 592 million by 2035. The number of people with type 2 diabetes is increasing in every country in the world, and 80% of people with diabetes live in low and middle income countries. The greatest number of people with diabetes are between 40 and 59 years of age, and diabetes caused 5.1 million deaths in 2013. And the really frightening statistic is that every 6 seconds a person dies from diabetes somewhere in the world. It is a global problem, it is a global pandemic, and it requires a global response. And that's really what the Melbourne Declaration for diabetes was all about. Parliamentarians representing 50 different countries came together to talk about what was happening in their countries, what the problems were, to discuss how we could cooperate better in the future. And what we had recognised was that many bodies work transnationally. Patient bodies, medical professionals, pharmaceutical companies, they meet regularly on a transnational basis. But one group that doesn't are parliamentarians. And yet it's the parliamentarians who can initiate debates. They can vote on budgets. They can raise awareness. They can put pressure on governments in a way that other bodies cannot. And in a sense, the parliamentarians are the missing link. And so bringing those parliamentarians together, to work together, to commit themselves, to be advocates for diabetes, to recognise the global challenge, those who attended committed themselves to raising the profile and to working for the benefit of people with diabetes wherever they live in the world. And since the declaration was signed, over 100 parliamentarians have signed up as members. Many, many more have declared themselves as supporters. 2 newsletters have been published, which are hosted on the International Diabetes Federation website. A Twitter account is now active, and debates have occurred in Russia, in Bolivia, in Malta, in Kenya, in Scotland, and here today in the United Kingdom. But there are so many issues to address. One area is prevention, and far more needs to be done. We may well have reduced the number who are missing diagnosis, but there are still 750,000 people out there with diabetes whose condition and whose cost to the health service will increase the longer they go undiagnosed. Health education, vitally important to make people aware of what the risks are of finding that you have the condition of diabetes. And we need information out there to combat the fears that people have, that if you're diabetic, you're going to have a life injecting yourself with needles. Well, only 10% of people with diabetes are type 1 who do have to take insulin subcutaneously by injection. And believe it or not, once you're confronted with the fact you've got to inject yourself with a needle or you're going to die, suddenly you don't worry about injecting yourself with a needle. But 90% of people with diabetes don't have to worry about that. They can be treated by diet, by tablet, and different regimes. And there's the stigma that's still there. There are members of this place who have diabetes but do not really want other people to know about it. And I think it's very good that increasingly members are prepared to come forward. It's the same in other professions. And one of the great things the All-Party Group for Diabetes in this Parliament did was get a change of policy by the police, by the ambulance service and by the fire service. So instead of immediately retiring people who admitted that they now had the condition of diabetes, are now given individual annual medical assessments to see what they can and cannot do. And that, to me, it just seems so obvious that it was an injustice to sack people simply because of a condition when many of them could control it, could hold down that job as well as any other person, so long as they were monitored and had that medical assessment. Prevention will save millions. There's no doubt that the bulk of the cost of diabetes to healthcare systems is actually where the complications come in, where a person with diabetes has to be hospitalised. And it's an interesting phenomenon that people with diabetes stay longer in hospital beds than people without diabetes. And that includes people who've been admitted to hospital or have gone in for elective surgery that has absolutely nothing to do with their diabetes. And it's the change of environment and the change that occurs in going into hospital that disables them in being able to control their condition. And increasingly now many hospitals are saying that because people with diabetes basically self-medicate 365 days of the year, that if you go into hospital, well, you may as well carry on self-medicating because you know your body better than the health service is likely to. But the savings to the health service from prevention are quite phenomenal. Diagnosis is important. Early diagnosis reduces complications, and so we need to encourage people to come forward and be tested, and that's linked into that education and information campaign so that people don't fear being tested, don't fear being diagnosed with the condition. Treatment. Well, many people with the condition, sadly, are not getting the checks they are supposed to get from our health service. This is something that Diabetes UK has taken up and has been arguing that everybody should be entitled to 15 checks whenever they go to their GP once a year for their annual checkup. And the fact that they are not getting all 15 checks suggests that something is not working correctly within the system. And of course, we do have some GP practices that are excellent, but there are others that are not so good, and we need to ensure that everybody gets that minimum of 15 checks that they are supposed to. Pump prescribing. Now, the pump device, for those who are insulin dependent, is just a small device about the size of a pager that's attached and gives you insulin doses almost mimicking the pancreas. And of course, this is a very, very good regime, particularly if you're a child who doesn't want to have all the paraphernalia of injection pens and all the rest of it, and can actually enjoy a life that other children don't recognise you as being different, because it's there and it's doing the job for you. Still have to test your blood sugars, and we are looking and hoping for the development of a single device that both tests blood and injects insulin and completely mimics the pancreas. It's there, it's out there, but it's not yet widely available, and its cost does need to come down along with more testing that needs to be done. But that is the future. People actually have to live now, and our pump prescribing is well below the levels of other EU countries. And it seems to me that any child diagnosed with diabetes should just automatically put on the pump unless there's an objection not to have that pump. It is the obvious way of getting a child to control their condition early on and to enjoy their life along with all the other children of the same age. There's also the issue of the treatment of people in care with diabetes, which leaves a great deal to be desired. And I think a lot more needs to be done there with the various care inspection regimes to ensure that people with diabetes who go into residential or nursing care are properly looked after. Then there are questions around research. Are we spending enough on research for a cure, or researching better conditions and finding the best treatment regimes for people with either type 1 or type 2? Then the supporting children with diabetes in schools, and I hope that the recent bill, Families and Children's Bill, now an Act, will actually go some way to helping some of the problems that parents in the past have found with schools that refuse to deal with a child with diabetes, in terms of helping that child test their blood sugar levels or indeed take their insulin, and in some cases insisting that a parent always has to be in attendance at the school, which of course is often taking somebody out of a job in order to be a full-time carer for their child with diabetes in school. That surely is not a desirable situation. And then there are complications around transition. Children moving from primary to secondary and then to university, and they're then dealing often with 3 different healthcare regimes: paediatrics, adult care, and then student care services. And the problems that can often arise as a consequence of those transitions. I mentioned discrimination in the workplace in relation to blue light services that we were able to campaign and help tackle, but that discrimination is still out there. And again, it's people having the courage to come forward and take cases for discrimination on the grounds that they have diabetes. And I think there's a much better understanding probably out there in the workplace about what diabetes is, but there are still pockets, if you like, of ignorance that need to be tackled. And all of these are just in the UK, with its well-developed healthcare service that in many aspects is the envy of other countries. And I think the study that has come out this week showing the UK health service, the Commonwealth study, at number 1, I think is testament to everybody who works in the healthcare service, and they really do deserve our congratulations for delivering such a fantastic service cost effectively for the majority of people who need to access its services. So whilst I list a whole load of issues and problems, it would be wrong to be all doom and gloom. and to think that we are somehow lagging behind. We are actually way out ahead, but we want to be even further ahead, and we want to bring other countries up to our level as well. We must and we can do more. Internationally, the 66th World Health Assembly adopted a global target to halt the rise of diabetes and obesity by 2025. And every nation needs a national strategy and action plan to prevent and manage the diabetes pandemic. And I think it is unfortunate that we no longer have a national service framework for diabetes in this country, and I really think the government needs to think again on that, because without that national plan, without that national strategy, it's very difficult to determine how we are achieving what we wish to achieve in terms of reducing the number of people with diabetes, in terms of diagnosing those who have the condition, and ensuring that treatment is as good as the best anywhere in the United Kingdom. Now, the Parliamentarians for Diabetes Global Network, which was set up through the Melbourne Declaration, I think can help and facilitate the objective that the World Health Organization has laid down for healthcare systems around the world. The priority of the Parliamentary Diabetes Global Network in its early years will be to build a coalition of advocates for action to prevent the pandemic at local, regional, national and transnational level, with the focus on raising the matter in parliaments and assemblies across the globe to spread better understanding and awareness of diabetes and the urgency with which it needs to be addressed. Following the declaration and events in parliaments around the world, the Expand Diabetes Toolkit has gone live that will greatly assist the aims of the declaration. Now, the Expand Diabetes Policy Toolkit is a practical guide to help diabetes advocates challenge national governments to raise the profile of diabetes. It is the first comprehensive resource aimed specifically at helping MPs and other policymakers to shape and influence national policy to ensure we prepare our healthcare systems for the challenges of the 21st century. With input from parliamentarians for parliamentarians, it provides a one-stop resource covering the economic case for investment, evidence of what works, and best practice from across Europe, as well as practical steps for leading and developing new diabetes policies fit for purpose. Key topics include prevention, self-management, innovation, and person-centred care. There are also dedicated chapters to care and treatment of children and older people. It is hosted on the International Diabetes Federation website and is available for any parliamentarian anywhere in the world who wishes to avail themselves of its usefulness. Now, the toolkit itself was the result of over a year's work by a network of parliamentarians, patient representatives, and other opinion formers from across Europe. Mr. McRae, while the Melbourne Declaration is a clarion call for action across the world, and the Expand Toolkit is a resource to turn words into action, we also need momentum to reach that tipping point where no one questions why the global pandemic of diabetes receives priority attention for resources to prevent, to diagnose, and to treat the condition.
Mr. Jim Shannon.
Thank you, Dr. McRae. It's always a pleasure to come and make some comments in relation to diabetes. I register myself as a type 2 diabetic, and before we start the debate and my contribution, because obviously it's something that's very important to me, and I congratulate the honourable gentleman from Torbay for bringing this forward. I know of his passion for this year. It's always good to come along and participate in a debate initiated by him, but by others who will make a contribution that hopefully will help the honourable gentleman go forward with his own ideas. Let me say first, Dr. McRae, I'm very much fully behind the Melbourne Declaration on Diabetes. I'm delighted at the attention this illness is getting, and I look forward with anticipation to great steps being taken to curb the effect diabetes is having in our country and in the world. Many people refer to diabetes as the ticking time bomb. Of all the diseases we have, with many ones we feature upon cancer, we feature upon heart disease, and diabetes is one of those ones in there that is a ticking time bomb because of the numbers of people, Dr. McRae, who have it and don't know they have it, and those who will potentially be a diabetic sometime in the near future. As I'm sure you're all very aware, it's estimated there are 382 million people worldwide with diabetes, most of who are aged between 40 and 59. Again, that middle-aged group, Dr. McRae, is where the focus seems to be. Their number is expected to rise to 592 million by 2035. Just for 1 second, Dr. McRae, just remember what those figures are. From 382 to 592 by 2035, almost another 200 million people will be diabetics by that time. In 2013, diabetes will have caused 5.1 million deaths. That is 1 in every 6 seconds. And the magnitude of this issue of diabetes and what it is doing and has a potential to do. Excuse me, in world monetary terms, diabetes is taking up some 548 billion US dollars in health spending in 2013, right across the whole of the world. That is 11% of worldwide expenditure. Again, just to get into figurative numbers, what it means to be a diabetic in the world and why it is a ticking time bomb, not for the United Kingdom only, but for the world as a whole. These statistics, Dr. McRae, are harrowing. This is an international problem. It's a disease that we are often too blasé about, and we must not let this dire situation continue. We must adequately assess the issue of diabetes and tackle the problem head on. In many cases, I just want to make the mention, if I can, Dr. McRae, of our colleague, Edwin Putz, who's the Health Minister in Northern Ireland, who has initiated the insulin pumps for 400, which were brought in to go out and help those families who were type 1 diabetics. He's also initiated training along with those two, so that the people who have them are adequately trained to be able to administer and to help the ministering and control of diabetes. Again, some good things been done in Northern Ireland, but I have to say, Dr. McRae, there's good things been done in England as well. I say it all the time, and the Minister will know that. I often ask about a strategy, not just regionally, but a strategy for the whole of the United Kingdom. Obesity and diabetes-related illnesses combined cost the NHS an estimated £15 billion per year. 80% of the available funding for diabetes is spent treating preventable complications, because it's not the diabetes, Dr. McRae, that will initially, I can use these terms in very strong terms, kill you. It'll be the complications. It's your kidneys, it's your liver, it's your circulation, it's your heart, and all those things, and your eyesight as well. Yeah.
Thank the member for giving way. Just when he's on the issue of the cost to the NHS and to all of us as taxpayers, would he agree with me that any additional resource that can be deployed in early detection and trying to ensure there's greater awareness right across our communities across the UK, that will vastly be outweighed by the savings that the taxpayer will have to pay in terms of money saved that has been outlined both by my honourable friend and yourself?
I thank my friend and colleague from East London Derry for that comment. He's absolutely right, and just in a few moments I hope to come upon some of the issues which I feel that the government needs to address early on. And he's right. The honourable member is correct to say that there will be vast savings made if early detection takes place. And I think the issue which and I think the honourable member in this introduction from honourable member for Torbay, he was also referred to the need to have early detection as well, and other members will make the same comment. While it is great there is money available to treat this illness, we must not merely chase after it, putting a plaster on it after it has inflicted damage. And that's very clearly the issue. We need to ensure that money is not just spent on treating, but also on prevention methods. Which makes me wonder, was the honourable gentleman from East London looking over my shoulder at my notes, because that's what was my next point I was coming to. We cannot allow ourselves to be accepting of the fact that 3.2 million people in the UK have been diagnosed with diabetes. Again, the magnitude of this problem and of this issue. We must look at the causes and stamp them out at the root. And that's one of the issues that we can address in preventative measures that need to be done. We have talked many times in this House of sugar content in food, and the honourable gentleman who's not here for Leicester West, I think it is, who I'm writing that one, Yeah, and he is, along with myself, well, he initiated, but I was quite happy to sign that we should be looking to address the issues of sugar in manufactured products, which we then indeed eat. I think that's an issue that we need to take forward as well. And sometime in the future, I do hope that we will be in a position to bring that legislatively to this House with the support of the manufacturers of food, but then to address the issue, the very clear issue of the food that we eat. We don't need all the sugar content in food, and as I say, we don't need all the salt content in the food either. So there is a way of addressing issues outside of this chamber and outside of government's control, but something that needs to be done at a manufacturing level. Our annual intake of sugar is 33.7 kgs per capita. And just to put this into perspective, it's equivalent of eating nearly 34 average-sized bags of sugar each year. Can you imagine the sugar was piled up there? It would block my honourable friend from East Londonderry completely out. That's how much sugar we're all eating every year. Some people even eat more. Surely when discussing the Melbourne Declaration on Diabetes, the government needs to take another look at the sugar levels in our food. Let me ask Dr McRae, what steps is government taking in diabetes prevention to ensure the next generation isn't blighted by diabetes the same way as this one is? Projections show that if current trends continue, that in 2025, 5 million people in the UK will have diabetes. Again, the magnitude of that is very clear. What, again, is government going to do to ensure this doesn't happen? What preventative measures are they putting in place to decrease that number and that number of people? The correlation between weight and diabetes has been made very clear. 80% of people with type 2 diabetes are overweight or obese. The government needs to do more to increase the education as the danger of being overweight or obese and tight controls on how much sugar is going into our food. Again, these are all issues which I feel we need to take on board. What is so frustrating, Dr McRae, is that up to 80% of type 2 diabetics could be delayed or prevented. I'm not saying this in any judgmental way at all, because many in this chamber will be aware that I'm a type 2 diabetic. I declared it at the beginning of the speech. And the honesty of the matter is, Dr McRae, I have to blame myself and my lifestyle choices for the onset of this disease. It was the Chinese carry-out 5 nights a week with 2 bottles of Coke. Not a good diet for anybody. It was the reason why I was almost 18 stone and had to lose it very, very quickly. But aside of that, it was also a lifestyle with high levels of stress. When you combine the two, diabetes knocks the door of nearly everybody. Most of us know. And by the way, just on the subject, many people can be diabetics even if they're not necessarily overweight. They can be through their lifestyle of stress as well. How many others living the same lifestyle are not aware of the damage that they are doing to their bodies in the long term, and how can we do better in highlighting this? At this moment in time, Dr McRae, I have to take 2 metformin tablets in the morning, 2 at night. I'm a type 2. The fact is, if it continues, that dosage of medication could have to be increased. And as a doctor comes along, as he often does, he says, by the way, you just need a wee blood pressure tablet now to keep you right as well. So you won't just how many tablets you're going to have before you march on to the age of 65 and retiring, if we're spared to reach that. What is the government doing to diagnose diabetes early and treat it effectively, preventing or delaying the complications that cause so much human suffering, costly treatment, and reduces life expectancy? As it stands, only 1 in 10 people who are newly diagnosed with diabetes are offered education on how to manage their condition. Despite strong evidence, education is a cost-effective way of giving people the knowledge they need to manage their condition. So, Minister, I would ask you this question. When it comes to management, diabetic is diagnosed, what help is given to him or her to ensure that they manage that in a sensible way? I have to accept, Dr McRae, the person needs to also acknowledge they have to manage it, because many times, I remember Dr McGeehan, my doctor, telling me whenever I was first diagnosed, he says, Jim, it's up to you what you do. And he was very clear, you must manage your own. But at the same time, I think maybe we need a wee bit of help, perhaps maybe from government and from the health service in particular, just to ensure that we know what that all means and for everyone involved. In my small province of Northern Ireland, it is estimated that 80,000 people have diabetes, an awful statistic, and one that worries me very, very much. And worry. Quite, yeah.
Interesting point on education. According to the National Audit Office, the estimated amount the NHS could save annually through better understanding and management of people with diabetes is around £170 million. Wow. That's just really from just improved awareness and education.
I thank the honourable gentleman for his intervention, and that reinforces the point made by my honourable friend and by myself as well. Prevention saves money for the NHS, and I accept that the Minister and her budget is a restricted budget, that we can't spend outside of that. But if there are ways of means that we can reduce that budget and ensure we can still deliver the NHS, or the NHS that we're all very proud of, then we should try to do that as well. On the 12th of February 2014, I asked the Minister a question that was, what discussions have been had with the Minister for Health in Northern Ireland on UK-wide strategies for diabetes, for obesity, for heart and rare diseases. At that time, the Minister replied to say that there had been no discussions with the Northern Ireland Executive on a UK-wide strategy for diabetes, obesity, heart and rare diseases. I'm asking again, Dr McCrae, if I can, because the Minister's here. I respect the Minister greatly, she knows that, and I value her position as she carries out in this place. But I do honestly believe that there's a need for a UK-wide strategy. We had one up until 2013, then it wasn't carried on. Dr McCrae, I believe that's to the benefit of all of the regions of the United Kingdom of Great Britain and Northern Ireland if that UK-wide strategy starts again. And so I would ask again that with cross-house approval and support of the Melbourne Declaration on Diabetes, which pushed for an international effort in the fight against diabetes, and that's what this is all about. It's an international effort to fight diabetes. That's what the Melbourne Declaration means, and will government now be willing to work with the devolved assemblies of Northern Ireland, also with Scotland and Wales, to use resources wisely and create a UK-wide strategy against diabetes? They've done it before. Let's do it again, and let's do it even better this time. The Director of Diabetes UK NI, Ian Foster, said, "We are in the middle of a diabetes epidemic. With the numbers rapidly increasing, it is now more important than ever that everything is done to prevent the serious complications which cost the NHS hundreds of millions of pounds," as the Honourable Gentleman for Torbay said, and are absolutely devastating for the individuals and their families involved. Because let's never forget, Dr McCrae, that it's not just those with diabetes, it's their families around them who are also impacted upon the particular debilitating effects of diabetes upon the individual. Will government commit to fully implementing the NHS health check, which should be offered to everyone aged 40 to 74 to help identify people at high risk of type 2 diabetes? This programme, with respect, has been patchily introduced so far, so therefore there's a lot of improvement that could happen. Government needs to do more to ensure that those at high risk are given lifestyle interventions to help prevent it. And the National Institute for Health and Care Excellence has recommended increasing the proportion of people with diabetes getting the 9 annual checks. And that's something that should be a matter of course in your GP surgery, or should be a matter of course if you're in hospital for whatever it may be. These checks help people manage their condition and identify any signs of complications early. There is currently, however, large geographical variation in the proportion of people getting them. And again, I think if we had a UK-wide strategy, we could ensure that there wouldn't be any differences geographically to those who are getting the 9 annual checks and those who perhaps aren't. Will government commit to increasing the people who receive these checks? I believe it's a positive way forward. It's another way of giving the prevention that we need to have, and will ultimately lead to the savings that we need. In conclusion, Dr McCrae, in 1922, insulin was discovered by John MacLeod, Dr Banting and Charles Best. Yet 92 years later, in 2014, we are still fighting against this dreadful disease of diabetes. In the UK, in this year, 59,000 people die unnecessarily from diabetes. I strongly urge the government, in the wake of the Melbourne Declaration on diabetes, to take serious strides in the UK to preventing and controlling diabetes. Thank you.
I call Jimmy Reid.
Thank you, Dr McCrae. It's a pleasure as usual to serve under your chairmanship. And it's a real pleasure to follow both honourable gentlemen. I think in particular the honourable gentleman for Torbay, who's made a superb contribution across this entire policy area for many years now. And as somebody who also is blessed with type 1 diabetes, I do look to him for inspiration, and he readily provides it on a regular basis. And I really can't thank him enough for introducing this debate yet again to the House today. I have to say his work as chair of the All-Party Parliamentary Group on Diabetes, as president of the Parliamentarians for Diabetes Global Network, and at the Parliamentary Champions for Diabetes Forum is absolutely commendable, and his position and work there means that the UK can be a world leader in ensuring high-quality treatments and support for those with diabetes. I'm very, very sincere with all of those comments. They are heartfelt. He recently spoke in a debate on this subject in April, in which I also contributed, where he raised some very important issues, not least of which the importance of an approach that respects the distinction between causes and treatments of type 1 and type 2 diabetes. And in opening today's debate again, he's raised matters of the utmost importance and concern, which I will go on to touch upon. The Melbourne Declaration on Diabetes was formally adopted on 2nd December 2013, as we've heard, at the very first Global Parliamentary Champions for Diabetes Forum. The declaration contains 8 action points for parliamentarians, including encouraging the creation and adoption of a national plan, which acknowledges that diabetes is a national health priority and that this plan leads to action. It's the creation of an action plan and the need for that, which I'll focus my remarks upon today. I hope the Minister, who are welcome to her place, is able to confirm that the Government is committed to this, especially given the clear will of parliamentarians from those parties that have contributed today. But I have to say, in discussion and conversation with colleagues right across the House, there's a clear understanding of the need to support such a way forward. There are over 380 million people with diabetes in the world today, and that figure is expected to reach almost 600 million by 2035, and this is deeply worrying. In the UK, there are 3.2 million people living with diabetes, including almost 35,000 children. £1 in every £10 spent by the NHS is on treating diabetes and the complications that arise from it. We've heard an awful lot about the economic and financial modelling and the effects of diabetes in the NHS, and I do think we need to spend more time on this actually as a country. Diabetes UK say that diabetes is responsible for 20,000 premature deaths each year, and that 80% of cases of type 2 diabetes can be prevented or delayed. Just think of that, 80% of cases prevented or delayed, the savings that we could make there, irrespective of the real improvements we could make to the lives of those people who go on to develop type 2 diabetes. The financial savings at stake there are absolutely phenomenal. We must always be aware of the distinction between type 1 and type 2 diabetes. Type 1 is a chronic life-threatening condition that affects 400,000 people in the UK, including 29,000 children. Type 1, as we've heard, is not caused by lifestyle factors such as obesity, lack of exercise, or poor diet. I should know, and I never resist the temptation to remind people, because I did the London Marathon earlier this year, thanks to Juvenile Diabetes Research Foundation, who are here in the room. I want to do it again next year, by the way. Whereas those with type 2 diabetes can sometimes be treated with a change in diet and exercise and modest medication. Those with type 1 diabetes need multiple insulin injections or pump infusions every day. I just did mine before the debate started. 14.7, not particularly good. I will be getting told off for that. Each year, a person with type 1 diabetes will undertake more than 2,000 finger prick blood tests, have 1,500 insulin injections, and count the carbohydrates in more than 1,000 meals. So it's clear that any action plan will have to develop coherent and effective strategies for both conditions. A one-size-fits-all strategy just simply will not do. So I hope the Minister will be able to reassure us today that she won't be cutting corners on this. Any plan must be workable and must be tailored to meet the specific needs of both conditions. Diabetes UK has done excellent work, as always, on this matter. The briefing for today, in advance of today's debate, was absolutely superb. And they endorsed the clear need for a national action plan. And they've identified 5 key areas that must be included, which I'd like to touch upon. These are, first of all, improvement in support for self-management. Secondly, integration of care. Third, improving safety. Fourth, a focus on children and young people with diabetes. And fifth, the prevention of type 2 diabetes. So if the government was to bring forward a comprehensive action plan that was built upon these 5 principles, I'm sure that it would receive the support of the entire House. Starting with self-management, it's obviously crucial that an individual and their family must be in a position to successfully manage their condition. And the keystone of this is effective care planning and effective education. Positive care planning and strong education can ensure that an individual is equipped with the tools and resources needed to effectively manage their own condition. Diabetes UK calculates that each year Care in a clinical setting totals around 3 hours, whereas self-care accounts for almost 9,000 hours of a diabetic's care. Improving self-management is not optional, it's absolutely essential. I appreciate that this could be culturally difficult for us to achieve as a parliament and as a country, but it's something that we absolutely do need to crack. Members on this side of the House have long advocated the benefits of integrated care across the whole of the National Health Service. And with diabetes, a person will have contact with many different parts of the wider healthcare system on a routine basis, such as primary care, community care, and secondary care. To improve integration, Diabetes UK has identified 5 key points which would in effect provide an integrated care diabetes pathway. This requires strong networks of clinicians, commissioners and patients, a more integrated system of commissioning services, better information sharing across services, the raising of skills in primary care, and all of which should be overseen by effective clinical governance. These actions are not out of reach, and the government could easily ensure that they are part of any action plan. The third point I want to cover is patient safety. There are major issues regarding the safety of inpatients in hospitals with diabetes. Around 40% of inpatients experience at least one medication error, more than a fifth experienced one or more hypoglycemic episodes, and fewer than a third were seen by a member of the diabetes team, according to research undertaken by Diabetes UK relating to the last year. These problems can contribute to patients with diabetes having to remain in hospital, as the Honourable Gentleman said, more than 3 days longer than patients without diabetes. Again, consider the cost implication of that for the service in these tough times. And any plan brought forward by the government must surely address this, as it's bad for patients, it's bad for clinicians, it's bad for the service. There must also be space in the plan to address young people's experiences too. There are 35,000 children with diabetes in our country, and the UK is the 4th highest number of children diagnosed with type 1 diabetes in Europe. Many children and young adults experience a marked deterioration in their care as they make the transition from children's to adult services. Adolescence is often a time when many lifelong behaviours are established, including those that are health-related, so it's essential that young people are able to complete a transition at a time that is right for them. A deterioration in care and forced transition has been shown to disengage young people with the service, resulting in worse outcomes and complications, and there's a real acute need to address this. I made reference in the last debate on this issue in April with regard to support and education for young people, and this is absolutely key to ensuring that they're able to manage and cope with their condition. Being diagnosed with any form of diabetes can be overwhelming without the proper support being in place. The final point on this is in reference to a focus on preventing type 2 diabetes. Recent reports by the British Medical Journal have shown that a third of adults have higher than normal blood glucose levels, which is an indication of what is known as pre-diabetes, and many health professionals are projecting a huge increase in the numbers of those with type 2 diabetes. I'm sure this is something that worries us all, policymakers on all sides of the House, whether we're left, right or centre. And as I said previously, any action plan must take into account the differences between type 1 and type 2. And clearly, the critical element of any strategy for type 2 must be based upon prevention. So I'd be grateful if the Minister could outline what the government is doing in relation to the points I've raised, and I would expect that she would be able to give the House some indication as to when government is likely to bring forward some plans to address this issue. Given the importance of the plan, I would also hope that the Minister will make a statement to the House whenever the plan is published, in order to give members not present today the chance to scrutinise the government's proposals. And I would go further. Every time we have a debate of this kind, it strikes me that there's a real wealth of experience and understanding across the House about these issues. And so I think it would be a tremendous gesture, not for its own sake, but from the point of view of those people living with this condition throughout the country, if those members who do understand what they're talking about with regard to type 1 and type 2 diabetes were brought in and then allowed to contribute their knowledge and their experience towards the production of a better plan which would better suit those people in our country with this condition. The International Diabetes Foundation, through the Melbourne Declaration, makes an incredibly important point. And the Melbourne Declaration itself points out, and I quote, "Disadvantaged people in every country carry the greatest burden with regard to diabetes." This is an incredibly important point, and this is an incredibly important point when it comes to looking at the clinical levels of diabetic care across CCGs throughout England too. And to make self-management as effective as it can possibly be, and I think we have a long way to go in improving the culture around self-management, and not just the culture but also the the clinical ability of CCGs and other primary care providers around self-management. In order to improve that, we really do need to look at, and I've seen this myself speaking to diabetics around the country, we really do need to make a concerted effort to look at the literacy and numeracy among some people with this condition. When every day, before every injection, people are faced with undertaking what is a fairly simple and routine mathematical calculation according to an individual's insulin ratio with regard to carbohydrate. Many people simply can't do this. They simply can't do the maths. And there's nothing on the marketplace with regard to any kind of assistance or tool or device that can really simply help these people make those calculations either. So it's something we need to look at. There's a big cultural issue there. It's not just numeracy, it's literacy too, and it's other issues to do with social exclusion, which I'm sure we're all aware with, which we do need to put some time and effort into understanding and resolving if we're going to increase properly self-management amongst diabetics. NHS England, of course, published Action for Diabetes earlier this year, but Diabetes UK has said, and I quote, "It isn't sufficient and doesn't present a comprehensive strategy or action plan." I've read it, and I think that's a fair comment. Diabetes desperately needs a national service framework. There's no two ways about that. There's an incredibly patchy service around the country when it comes to not just the 9 key diabetic tests, but other diabetic support services. Perhaps the Minister could tell us how the government will ensure that CCGs step up to the plate on this. We really do need a detailed plan, and hope she can tell us when that will be being brought forward. Could she also tell us how many diabetics are actually missing their checks? This is a really important issue, and it's the kind of information which should be understood and collated centrally, because this is an issue of strategic national clinical importance in my view. And what are the effects of these people missing their appointments, both clinically and financially, upon the service? It is my view, and this did not begin in May 2010, that we are failing people with diabetes in our country. So self-management too, I touched upon earlier, is an incredibly important issue, but so is innovation and the use of data. So for me, as a type 1 diabetic, the most important issue in the management of my condition is the data to which I have access to about my condition. It's really incredibly important. So that's my blood glucose readings, that's my insulin ratios, etc., etc., etc. And we need, I think, a framework and a strategy for medical innovation in this country, which really incorporates diabetes research in a profound way, not just diabetes research from a scientific point of view, but from a patient's point of view as well. How can we become the best country in the world for medical companies, other pharma-based industries to develop new and innovative ways of treating diabetes? I wear all sorts of devices to monitor my fitness and my sleep, whether it's a Jawbone, whether it's a Misfit Shine, whether it's a Nike Fuel Band, whether it's, believe me, I've got them all. And we can certainly, the data that they capture about the individual is of incredible medical importance, actually. I think what we need to do is to establish on a cross-party basis a strategy whereby we can really genuinely innovate and become a global leader with a view to enabling companies to produce the best kind of suite of devices, applications and so on, which can assist diabetics, whether type 1 or type 2. I look forward to the day where my data can be captured in real time and shared with my GP and my pharmacist, so that I don't have to phone up or text or write an email for my insulin prescription. They will know, they'll have the algorithm, they'll know when it needs to be ready, they'll know how much I'm using, the doctor will know that, the doctor will know how I'm managing my condition, etc., etc., etc. And I think we can hothouse innovation in this. And I think if we are going to hothouse innovation in this, and me and my office are doing an awful lot of work on this at the moment, then we really do need to make this kind of innovation part of not only a national diabetes strategy, but also part of a biotech and a medical innovation strategy as well. Finally, I would say to the Minister, we're here to help. So please utilise the experience that exists across the House, and please don't miss this opportunity to act.
Before I call the Minister, would I say to the Honourable Member for Torbay and also to the Minister that a number of Honourable members of the House apologise for their non-attendance because taking part in another debate, and they'd like to have been here personally, so they wanted me to pass on that apology both to the honourable member and also to the Minister. Minister, call Minister to respond.
Thank you very much, Dr McRae, and thank you for those words. I'm aware there are some colleagues who would very much normally be with us for this debate on this important topic, so, but I know that some of them have been contributing in the other chamber, in the main chamber, and no doubt we'll catch up with the debate online at some point. Can I thank both my honourable friend who opened the debate and all who've contributed. Another thoughtful debate on diabetes, which, as my honourable friend for Torbay said, such an important topic. So I'd first of all like to thank, start by just, congratulating him on his recent election as the first president of the Global Parliamentary Champions for Diabetes Forum. I'm not sure he was a bit modest and didn't say he'd been elected as president, but I will give him due credit for that, and it's a tribute to his championing of this issue so effectively, and I think it's really important that we see that global initiative. As he said, we can't underestimate the global threat posed by diabetes. The numbers have been given by other members, but the IDF estimates that by 2035 there'll be 600 million people with diabetes worldwide, so 1 in 10 of the planet's population. And I think that the Honourable Member for Strangford described it as a ticking time bomb. But it is, as has been drawn out during the debate, one that there is no, for the most part, we don't have to accept the inevitability of that. There are things we can do, and I think it is right that we're beginning to talk about this as a global community and talk about it in global health terms. I think that's right. In the UK, obviously, we know that 3 million people are affected, with around, I think, 850,000 is our estimate of undiagnosed type 2. And we do estimate that by 2025 it will be 4 million if we don't make progress. Diabetes is a priority for the government. We've set clear objectives for the NHS and Public Health England to do more on prevention and improving care and management of people with diabetes. Now, I accept that there's been a challenge to say, we need a national action plan. I've had meetings with Diabetes UK, and I know that that's one of the things that in their briefing that they've mentioned. I mean, we have set up the health service so that we set very clear objectives to the NHS and to Public Health England, and we ask them to deliver against those objectives. So my contention throughout this speech is that we do indeed have a national plan, but we might be just delivering it in a slightly different framework for that's being advocated. But it should not be in any way underestimated what a priority it is and how important it is to this government that the health and care system works together at all levels to ensure that people living with diabetes are given the care and support they need. I hope over the course of the time I've been the Public Health Minister, I've been able to reassure colleagues of the personal priority I give it. Indeed, my first public outing, slightly terrifying me, was to talk to a meeting organised by the Honourable Member for Torbay, where absolutely everybody in the room almost certainly knew more than I did at that moment about the given subject. But I did attend that event to show at a very early stage in my ministerial role how important it was to me. I've met with the NHS's clinical director, and I'll talk about him and his role a little bit further. And I seek to have reasonably regular meetings with him because it's such an important area. I have an ongoing relationship with the All-Party Group and with the other diabetes campaigning groups and members in the House, and indeed on Type 1 met constituents of mine and other people's at the JDRF event, the Type 1 event. So I've attended that several times, and it's always a very humbling event when you meet these fantastic young people who have, at a very young age, learnt to manage and live with a very difficult condition. What's NHS doing to improve the management and care of people with diabetes? Well, as I mentioned, I've met up a number of times with the NHS England's National Clinical Directors. That's Professor Jonathan Valabji, who's been very generous actually in his time in attending parliamentary events as well. He's a great supporter of the work of groups and individual members in this House, and very regularly in attendance when events are focused on diabetes. He's the clinical director for obesity and diabetes, and very much focused on improving outcomes for people with all types of diabetes. And as I said before, earlier this year, Action for Diabetes was published, and that describes the actions that NHS England is taking to improve care. It covers many areas, some of which have been brought out during the debate. It includes developing GP contracts and incentives, working with primary care services to trial and roll out case finding, and I'll say a bit more about that, and also decision support tools to help detect and diagnose diabetes earlier. And I think through the whole national conversation we also have about obesity and about taking care of one's own health. And I think honourable members have touched on it in relation to preventing the development of type 2. Every member of the public is also a part of that conversation too, and actually we didn't really talk very much about individuals during the debate, but I think we would all agree that we do need to constantly re-emphasise personal responsibility too in the case of preventable or avoidable type 2. And I sometimes worry, and it's a conversation I had quite early on in when I became a minister with the head of Diabetes UK. I think perhaps because very few people are recorded of dying of diabetes, it is often the complications that come from it that I wonder sometimes whether there is a sort of a slightly more relaxed attitude amongst people who think they might develop diabetes that they would never in a million years have towards something like cancer, where they immediately identify the threat. So one of the things that we can do through debates like this and through the work that we all do is to really emphasise to people that although you might not know many people who you can say died of diabetes, you will know a lot of people whose diabetes contributed to either a premature death or a very long period of ill health. And I think that's something that we've got more work to do to get out there, because that's when we can really empower people to also help themselves. Of course, yes.
Said there now, because there are many people out there who see diabetes as a disease that, you know, we can manage it, it's not too bad. But you're right, the complications of it are far-reaching, and they have very final circumstances they can lead to. Does in my contribution, Minister, I talked about the education part of it. The reason why I talked about that there is because people have to manage it themselves, but at the same time, they need to know what they have to manage. And maybe that's the point I'm trying to make. Some people need to have that be enforced with the seriousness that you have very clearly outlined.
Well, I think that's quite right. We do need to make sure, I mean, people can't be empowered if they don't have the information. And we also know that with our duty to address health inequalities, that there are certain people within our community and certain groups within our community that find it much harder. And I was quite taken with some of the things the Shadow Minister was saying in terms of how we deploy technology more. There is some work going on in that area, but I think I agree with him that it's an area we can go far further, far faster on, to find ways of empowering people who perhaps at the moment don't have a good sense of what they can do to take care of their health, and find it harder than others to access the advice that is available. But we'd have to work harder to get it to them, and I'm going to come on to talk to a little bit about NHS health checks in particular. Let me just say a word about commissioning integrated care. So NHS England is working with other organisations to help promote services that are integrated around patients' needs across all settings, and there's been much emphasis on that. And they're implementing what they've called a customer service platform to allow patients with diabetes to self-manage through booking their own appointments, managing their prescriptions, monitoring the care they've received, and being able to view their personal health records. So I think that picks up on some of the points that the Shadow Minister was making. They've also produced a sample service specification for the management of type 1 and type 2 diabetes that's based on the NICE standards. It provides a model for commissioning that integrated care for those with diabetes, and it also highlights the specific needs for those with type 1 where they differ from type 2. If the current trial of the service specification is successful, it will be offered as a tool that all CCGs can choose to use to deliver high quality care. So that's quite an important piece of work in progress. I think there's always a challenge to any of us about how do you make sure that the rest are as good as the best, and I think that's always going to be a challenge. And actually, I think we're occasionally in danger when we talk about sort of the challenges in our current sort of health infrastructure. It always worries me that there's a slight assumption that there is a model out there somewhere that would absolutely guarantee you can deliver completely consistent care in any area right across the country. And I just think in a country like ours, it's just not possible to give that sort of guarantee, that sort of top-down guarantee. You've got to find a way of driving care, yes, from the top with clear sense of direction and that strategy, that mandate we've given the NHS and Public Health England, but also to make sure we put the tools in the hands of the clinicians, which is one of the things I was just talking about there, but most importantly that we empower individuals and patients to know what they can expect and to demand that good care. But I genuinely don't think there is any system you could devise where we could just issue a notice from the centre saying this is exactly how care will be delivered consistently right across the country. We have to find other ways to do it.
Thank you, Dr. McRae. Grateful to the Minister for giving way. I think I understand the point that she's making, but we're talking about, in the first instance, 9 simple tests here for people with type 1 diabetes. 9 very, very simple tests, 9 fairly cheap tests, but 9 tests which need to be done in a primary care setting, undertaken by medical professionals. We're talking about blood tests, we're talking about the processing of that blood and the results from that blood the data from that blood being made available to, all of which is critical to self-management of the condition. Surely we can insist upon these 9 tests for every single type 1 diabetic patient. Surely we can do that.
Well, but I think the Shadow Minister slightly misunderstood what I've said. Those are the tests, and that is exactly the standard that we want everyone to work to. I think what I'm saying is there is no top-down guarantee. You can't sit in Whitehall and say, this must be done like this and that's the end of it. We've said that is the standard. NHS England have set a whole range of other standards, but how we deliver that is how you drive that consistency of excellence right across the country. I just think you need a range of tools, and we have to acknowledge that. So it's not to say we accept patchy service, far from it. It's merely to say that I think you can't do it with just top-down diktat. You've got to drive change at all levels of the system and drive towards excellence. Of course, yes.
On this point, because I think there's a difference between a treatment which has to be down to the clinician and the patient and what's right for the patient, and tests which should be the same for everybody. I mean, they are just tests that then would dictate what the right treatment regime is, if indeed additional interventions are required. And there ought to be a mechanism for ensuring that those tests are consistent for every patient with diabetes in the country. Otherwise, what's the point of having the tests?
Well, I agree with him, and it is exactly, I mean, the government, NHS England, PHE, all of us are engaged in looking at what is the way we drive that consistency, what is the way we drive consistent excellence, what are the tools we can use to do that. Let me give an example, perhaps, which would be helpful. So Public Health England is developing a tool to drive just those improvements in diabetes care and iron out variation. It's going to be launched later this year. I'm not able to give as much detail now, but I'm sure he'll be interested when we are able to launch it. And that will provide a clear picture of how diabetes care and outcomes varies across the country and between practices to support decisions on how to make improvements. I mean, this government has made transparency of data a real priority, and I do think that by being very transparent about what's being delivered and about identifying variation, it's one of the ways we drive as I say, the rest to be as good as the best. I think all I'm trying to do, I suppose, was to try and get an understanding that it's not. I could send out a memo tomorrow saying this is my national kind of diktat on diabetes, but that's not how we drive change. It's crunchy, it's detailed, it's about getting to that local variation and making sure that we drive standards up in every way possible. And that's one of the tools that we're developing, but there are others as well. Of course.
Just in doing so, Minister, and my contribution, I referred to not just a regional strategy, but a UK-wide strategy. I'm hoping that the Minister would be able to respond to that, because the honourable members who have spoken as well have indicated about the need to have an English strategy in place, but there also needs to be one in Wales, one in Scotland, one in Northern Ireland, and the 4 need to work together so we can together address the issue. The Melbourne Initiative is very much a worldwide initiative, so the initiative, while you referred to England, has to be further. So what are we doing to initiate a UK-wide strategy?
Well, as the honourable member knows, health is a devolved matter, and that isn't at all to say that I'm not interested at all in what is going on in Northern Ireland, far from it, but it is a devolved matter, and therefore I think that clearly, and I've said this before in the context of other debates with him, there are an awful lot of things that we can learn from each other. Everything I come and report to the House in terms of progress we make and innovation in England, and indeed things that other health ministers report in other parts of our United Kingdom, all of those are things which people can learn from. There is no plan at the moment, I have no plan at the moment to have a UK-wide, because health is a devolved matter. If the Honourable Gentleman mind, I'm going to make some progress. But of course, it doesn't mean that we can't find those areas of joint working. The Melbourne Declaration shows us a way forward on that. And I think that's probably where we kind of end up with that it is devolved, but it doesn't mean that we can't share learning and knowledge and learn from each other's initiatives, as well as operating in that global context. Sorry.
I'm not certainly not been argumentative, and please accept that's my case. But we had a UK-wide strategy up until 2013, the last year. So we've shown that we can work together on it. All I'm really saying, Minister, is why not initiate what was there before in 2013, a 10-year plan that started in 2003. Why not initiate a similar plan where the 4 regions work together? And that would be exactly what the Melbourne initiative is about, and we were doing that because we've already done it before.
Well, I will reflect on his comments,
okay,
and perhaps we'll discuss it again. Just another area in terms of where we can make a difference to patients in terms of empowering them. Colleagues in the House might be interested to know that the Patient Experience of Diabetes Services Survey, which is part of the National Diabetes Audit, which I know there's always great interest in the House, and we answer a number of parliamentary questions regularly on that. But the survey is measuring the healthcare experiences of people with diabetes in England and Wales. It's an online collection of information from people with diabetes. It's asking questions about their care, and it uses a short validated questionnaire, and that's being tested, that online collection. Any diabetes service in England and Wales should be able to use this survey to get feedback from their patients, and we're looking to get the first results from the survey published this month or this summer, and I think that's going to be an interesting extra tool in the box for us to help drive not only drive excellence and to drive out variation, but also to empower local services to understand themselves at quite a local level what's going on and how satisfied their patients are with the service being provided. And I think that that can only lead to what I was saying before about the upward pressure, not least from patients, to improve services. Let me talk a little bit about NHS Health Check. Alongside the work of NHS England to improve the management of care of diabetes, the government's also looking to address the point which all members brought out in the debate, which is this issue about prevention and earlier detection. We are continuing to roll out the NHS Health Check programme. That identifies those aged between 40 and 74 who are at risk of diabetes and other vascular diseases, and it helps them to reduce that risk. Over 15 million people are currently eligible for NHS Health Check, and our economic modelling has shown it has the potential to prevent over 4,000 people a year from developing diabetes. And detect at least 20,000 cases of diabetes or kidney disease earlier. So that's all about helping people to better manage and improve the quality of their own life. Last year, almost 3 million NHS Health Check offers were made, Dr McRae, and almost 1.5 million appointments were taken up. And that was at a time of great change across the health system. And now what we're looking to do is to challenge the system to go further and faster and to continue to increase the number of people who participate. I've been out and about myself and seen some really great local initiatives on that. One of the examples I saw was in Southwark, where I visited an NHS Health Check team there, and I witnessed for myself the important conversations they were beginning with people in their local area. There's another example in Bolton, where health trainers have worked with 134 people identified through the NHS Health Check as being at risk of diabetes. The health trainers have supported people to make lifestyle changes, such as eating more healthily, increasing physical activity levels, and they've helped nearly half of the group to return their glycemic level to normal. So really good evidence of these effective interventions. In Tower Hamlets, where more than 50% of the population are from ethnic minority groups, there's been a very rapidly growing prevalence of type 2 diabetes. And to help combat that, Tower Hamlets have incorporated the Health Check programme into their managed practice network scheme. and I've talked to them about that, and I've heard about how they're approaching that. And Tower Hamlets has worked hard to ensure that all patients with diabetes have a care plan, and they've seen a 70% increase with that focus between 2009 and 2012. And also they have a big focus on the take-up of retinal screening for people with diabetes. And again, they've seen a significant rise. So we can see those local interventions can really work. And I firmly believe that a localist approach in some of these areas is important because, again, there is no one-size-fits-all you can devise in Westminster that would work for every community, and I think this sort of local innovation is really important. One of the things I do constantly sort of challenge myself to do is to think, how can we make sure that we spread the word about some of this great local action? We've taken some initiatives in that regard, but I think actually, again, Parliament has a great role to play there, and I encourage members to come and tell us of local initiatives that are really effective so that we can make sure we spread the word. We have got some research going on the NHS Health Check programme, currently underway by Imperial College London and Queen Mary University London, and that's going to improve our understanding of who's taking up the opportunity, what their risk is of cardiovascular disease, and the incidence of diseases such as diabetes in these groups. So we've got some work to come back there to understand how we can make those interventions count more. We've already touched a little on the issues of obesity and sedentary lifestyles. Again, physical activity is a big priority for this government. I've had a couple of meetings in the last couple of days alone, which have been looking at the cross-government action we're taking to try and hardwire physical activity into all aspects of life. We have a long way to go yet, because for too long it was left in a silo marked health. And it's more important than that. We know that all parts of local and national government need to address this issue of inactivity, which is one of the factors, again, that can help in that prevention with diabetes. I also touched very briefly on the responsibility deal. The government's been working with business. The Honourable Member for Strangford brought this out. The responsibility business has to look at calorie reduction, to look at clearer labelling of food. We're starting to see the calorie content and the contents of food displayed on the packaging of many, many more foods as we've rolled out consistent food labellings on a voluntary basis across the country. And the Change for Life social marketing campaign, which is one of PHE's flagship programmes, is also encouraging individuals to make simple changes and trying to work with them in the way the Shadow Minister was talking, to try and talk to people in language that makes it straightforward and easy to understand good choices you can make for the health of both yourself and your family. We're also seeing some encouragement from the National Child Measurement Programme with regard to childhood obesity. We know that there are far too many people who are overweight and obese, but we do see some signs of encouragement there. In 2012, childhood obesity rates fell for the first time since 1998. So we mustn't despair that the action we all take and advocate over many years, it can have an effect, and we do begin to see that happening, but it is never to underestimate how far we have to go. Just to conclude then, Dr. McRae, in 2013, the Global Burden of Disease study showed that the UK has the lowest rates of early death due to diabetes of the 19 wealthy countries included in the analysis. And the last data on diabetes care showed a 60% completion rate of all of the 8 NICE recommended care processes. That was a 5% improvement on 2010. So we see progress, but we know there is much more to do. The Melbourne Declaration is a timely reminder of the serious threat that this disease poses right across the world, as well as to us here. I can assure the House and the Honourable Member who led this debate and who leads the all-party group in such an exemplary way that it is a priority. We continue to work hard on it. We're grateful to see and pleased to see the progress, but we don't underestimate there is much more to do, and debates like this are a very welcome opportunity to keep this very firmly on Parliament's radar.
Mr. Saunders, we still have a few moments. Do you want to make a few closing remarks?
Very briefly, as there is a little bit of time, can I just say to the Minister that I don't think anybody recognised it was her first meeting when she came to her first meeting of the all-party group. She carried that off with distinction and very quickly won over a lot of friends in that group, and she has been a consistent friend, I think, throughout the period. Can I say one of the challenges that I think has been highlighted in this debate where we have a bottom-up approach, is actually getting people to use the information that is now out there in order to drive up standards. And I think it's about people being aware that where that information is and how they can best use it. And I think that's not just a challenge for diabetes, I think that's a challenge across the health service. Can I just thank all honourable members for their contributions?
I suspend the sitting until 4 p.m.